The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, extending medicine into more complex situations.
I'd suggest that what we're seeing is perhaps a tolerance of risk, a level of risk homeostasis.
That's Professor Andrew Johnson from James Cook University, a veteran medical administrator and former Executive Director Medical Services at Townsville Hospital, now working as a consultant. And he's answering a difficult question.
Now we're doing things for people who aren't really fit for a haircut.
In this episode, why we're not seeing better outcomes. It's nearly 30 years since Ransom and others published the Quality in Australian Healthcare study in the Medical Journal of Australia. It showed that back then, close to 17% of admissions to Australian hospitals were associated with an adverse event, and half of these were deemed preventable. 14% of these adverse events resulted in permanent harm. Yet recent studies have demonstrated rates from between 14 to 21%, so it appears little has changed despite the investment of huge resources in quality and safety initiatives. In a 2019 article he wrote for the Australian Health Review, Professor Andrew Johnson stated that the past 20 years of healthcare have been appropriately characterised by an increasing and relentless focus on improvement in quality and safety, but with little measurable improvement for patients. I started by asking Professor Johnson how come we've seen so little measurable change in outcomes despite this relentless focus on improvement.
David, this is the central question, isn't it? I mean, the reality for us is that, I would suggest that the emphasis here is on the word measurable. Do you honestly believe that healthcare today is no better than healthcare was 20 years ago?
I don't believe I would be a medical administrator if I hadn't convinced myself that I could make a difference.
Yeah, and we have. And with our systems of work, we have improved. With the research that's conducted into all forms of healthcare, there's been massive improvement. You think about, 20 years ago, 30 years ago, when you and I were junior doctors, a patient wouldn't be lined up for cardiac surgery if they were over 75. Now we're doing things for people who aren't really fit for a haircut. So we're still getting the same level of complications, perhaps, some of which are potentially preventable. We're still getting a level of adverse events that, we're very uncomfortable with. But I think the emphasis here is really on how we go about measuring improvement and whether, in fact, we're looking for the right thing. I'd suggest that what we're seeing is perhaps something a little different, and that is a tolerance of risk, a level of risk homeostasis. And this is something that is well described in other safety literature, and that is we might make improvements that allow for greater safety, that allow for reduction in complications, but we actually have a tolerance of risk. We have a tolerance of things going wrong to the extent that actually, as we get better, we're doing more complex things. We're taking on more difficult patients. We're dealing with a totally different patient perspective, a totally different level of complexity within the system now. So we've been trying to focus on eliminating those adverse events, those complications. We've been focused on trying to chase down and use an approach to safety that actually reduces harm rather than a focus on safety that looks to do more things right, to get it right more often. As we become increasingly complex, what we've come to recognize within the system is that actually that level of complexity and the level of interconnectedness has been ignored in much of the safety and quality work that we've done. We've tended to focus down on trying to, in a very reductionist sort of way, trying to pull out elements of care and treat them as if they come together to make the whole. And in fact, there's a huge level of interrelatedness, a huge level of interconnectedness. So what I'm suggesting is that we have got a lot better at healthcare, and we can see that. We can see the improvement in health outcomes. We can see the survivability of a whole bunch of cancers that weren't able to be survived, cardiac disease, all of these things. And what we're doing is generating a population with a whole heap more comorbidities that lead to increased complexity. We're generating a great deal more complexity within our system. So it's actually not a surprise that things go wrong. We perhaps should be celebrating that they go right so often.
You talk about this need to reduce complexity and unpredictability to the maximum extent possible. Isn't that cookbook medicine, taking away the individual clinician's autonomy?
It's exactly the opposite. What we do is we look for those elements that are suitable to be simplified, are suitable to be reduced in complexity, and we take those out of the complex picture. So rather than trying to simplify or remove components from treat the whole complex picture as if it's simple and reproducible, which would be your cookbook medicine, what we can do is look for those elements that are linear within the system, where we can establish a cause and effect, where we can reduce the variability of the inputs and generate through consistent processes a reliable result, one where we can actually see a direct relationship between the process and the outcome. So there are elements of healthcare where actually there's a real argument for that kind of perhaps checklists, protocols, etc. But if I was to ask you, let's say you're an endocrinologist, I want you to standardize the care of the diabetic patient, you'd look at me and ask what planet I reside on. But if I was to ask you, can you standardize diabetic ketoacidosis management, you might look at me differently and say, oh, hang on. Yeah, maybe we could. Maybe we could come up with something that's reproducible, where actually we take some of the noise away. And the beauty of that then, David, is it frees you up to do that cognitively loaded stuff where the human is the source of success. So this isn't about moving towards a cookbook medicine. It's actually taking the elements out of complexity that we can standardize, that we can put standards around to free us up to that stuff that only we can do with the higher order thinking.
I'd like to pick up on this idea of predictability. I've recently been working with a couple of PhD students looking at whether or not we can take the data we have available to us at admission and predict patients that will have a long length of stay or develop a complication. And I've been stunned that some of the algorithms can be 95 to 98% accurate in predicting. And yet collecting that data tends to be delegated to nurses, variably filling out forms, and often doesn't get converted into care plans. How do we pick up the data, the information that we've got about a case complexity and use it to tailor our care plans for those patients?
Great question. So here we move into the space of resilience in healthcare. Eric Hollnagel, perhaps the grandfather of the resilience movement and resilience engineering, talks about the resilience potentials. And here, when we're talking about resilience, we're talking about the capacity of the system at every level, from the individual through to the broader system level, to adapt and change to circumstances to deliver acceptable outcomes. And if we take this into what Hollnagel describes as the resilience potentials, we can offer ourselves an opportunity to think about how we anticipate. Resilience potentials are anticipate, monitor, respond, and learn. They don't need to happen in that order. They can happen in any order that they need to. But critical in what you're identifying there is the anticipate phase. And this requires us to be deliberate in thinking about what might happen. And here, a checklist might be appropriate, not so much for us to go into a compliance phase, but for us to anticipate what might happen. And this is about understanding as best we can what it is that we're looking at. Now, where you're talking about those algorithms, what you're doing is really identifying the number of factors that might come into play to make a case more complex, to make the achievement of an outcome within a specified time frame more difficult. And that'll be things like the availability of home care, socioeconomic status. Do they have family who are able to call in on them? Those sorts of things are almost as relevant as what are their comorbidities? What was the outcome of their last care? All of these things, if you think about the way that you might try and improve predictability in industry, where you are looking at perhaps a factory type system, what you do is look to absolutely specify your inputs. So if you're working in a steel factory, you'll be looking for the raw products that meet a very highly specified standard. In healthcare, our primary input is our primary variable, and that's the patient. So actually taking ourselves into a space where we don't try and apply a cookie cutter approach to our patients, but we look for that complexity. We look for the things that might confound our approach. And then after anticipating that, we think about how we might monitor for, are those things becoming a problem, and have an approach to responding to those. The moment we commonly just kind of blindly go in without thinking about those things, without getting ahead of the action, without having our senses tuned, if you like, to looking for the signs of what might be taking us off piste. So that kind of algorithm, it's not that hard. It's not rocket science. And yes, it does allow you to show that these patients are going to be complex. And when those patients are complex, they end up quite commonly in this, I call it a clinical futile cycle, where a patient with complex needs will come in and we investigate, we might medicate, operate, procrastinate, complicate, and they just end up in a cycle of lack of progress because we haven't actually applied an approach of bringing the experts around the table and saying, what is it that we're trying to address here? How can we deal with this in the most effective way possible? So we don't make that assessment of complexity, just as you've identified there. Now, can that be done by a nurse? Hey, why not? They're pretty good at intuiting this sort of stuff.
So often complexity is determined by, as you say, the socio-behavioural context of the patient. We make assumptions as doctors that if we write a prescription, the patient will be compliant in taking it. But when we admit a patient to hospital, we don't question whether they are a medication compliant person or a non-medication compliant person, which can have a huge impact on their readmission rate after heart failure if they're non-compliant. How do we ensure that we collect data to truly determine complexity?
Okay, you've used a few really important words in that question, and it's a layered question. Firstly, pick up on compliance. With compliance, there's, if you take that into a patient context, what you're doing is actually subordinating the patient to our direction, if you like. Are they compliant with our direction? If you think about the things that you will actually apply your energy to, it's the things that you are intrinsically motivated to do or you have been convinced are a good idea for you. And you're much more likely to do that if you've been part of the decision-making. And I mean genuinely part of the decision-making. So thinking about an individual in their space, can they actually get the medications? Can they afford the medications? Do they have a refrigerator accessible to them? What are the elements that go to a patient actually taking the medication that they want to take? They have to understand why this is important to them. They've got to understand what this is about to actually increase the chances that they are going to do what it is that you've agreed to do. We miss that step. Patient partnership has really commonly been sort of touted out there. Yes, we're going to get into consumer partnership stuff. And very commonly that's about putting the consumer around the committee table. That's not what it's about. It's actually engaging people as their own healthcare providers too. We've got to remember that if we reside in a model where we are purely treating patients, we are missing the reality that the vast majority of their care is delivered either by themselves or by their loved ones. So this compliance piece is really quite problematic, I think. And actually getting underneath what we describe as work as imagined versus work as done. So we have a theoretical construct in our head that if we give this direction, if you like, or this, we prescribe for the patient, that they will reliably take that without understanding their real world environment, their real world understanding. What is it that would drive them to want to take the medication that we are prescribing? So we miss that part. We write the script and we expect that they'll follow. But the first time they take the medication, they may find that the pill is too big to swallow. Lots of different things that we know can improve the likelihood of people taking medications get missed along the way. So I think a huge part of it is actually our lack of understanding of how that patient's world works and how their thinking works. It's a negotiation, David. It's not a direction.
You talk about dividing patient care into the three areas: reliable, robust, and resilient. Starting with reliable, one of the areas you pick up on is compliance. And this time, rather than patient compliance, it's healthcare professional compliance. So the Commission comes out with extremely valuable guidelines. Everybody acknowledges that they're very good, and yet simple compliance with things like aseptic technique is often horrifyingly lacking in day-to-day practice by health practitioners. How do you get health practitioners to improve their compliance with evidence-based medicine?
Yeah, there's no magic bullet for this. Let's start with having the message coherent. Let's start with having it easily articulated, why we're doing it, what the task is, and what happens if we don't do it. So let's take hand hygiene, for instance. You ask that question, go out and say, what are the 5 moments of hand hygiene? Because that's what we're measuring compliance against, 5 moments of hand hygiene that, frankly, are nuts. What is it that we want people to do? We want them to clean their hands.
No, we want them to reduce the rate of infection. And we very seldom give them back data on their infection rate, but we give them back data on their hand hygiene compliance rate.
And their compliance rate with stuff that actually doesn't make sense to them, right? Let's say we were to use a much simpler message. Let's say we were to use a message like wash or clean your hands before, after, and often. Before and after what? Before and after doing anything. And do it often. Because what we're doing is we're actually increasing the likelihood that they are going to have clean hands when they engage with patients. They're going to have clean hands when they engage with their environment. Our messaging is completely wrong with this stuff, as people will disengage with that complex message. But if you actually can deliver it in a way where we are talking about something that is doable, that they can keep in their head, and we've got to make it easy for them to do. You go through our major hospitals prior to COVID, and you have a look at how easy it was to conduct hand hygiene. Anything that's built more than 10 years ago has got one sink between every, 2 or 3 bays of patients. The prevalence of the alcohol dispensers was governed by the ability, to actually replace them and keep them filled. We're not making it easy for people to do what we want them to do. If we want it to be easy, there's got to be a sink beside every bed, or there's got to be an alcohol dispenser on every bed. You need to have a line of sight in the corridor from one to the next. It's got to be something that actually is there and present, and our messages need to be consistent and coherent. So I think when we talk about things as basic as hand hygiene, for instance, when we are missing the point that this needs to be communicated in a way that makes sense. If people look at it and go, that's nuts, you've disengaged them from the process completely. That's a really nice example, I think. Then if we're wanting them to actually engage in and do the stuff that's truly important, there is ways that we can do that. If you look at how military or police do this sort of stuff, where it's actually them that are at risk. You can use things like Itiel Draw describes as the terror of error. And this is where you've got to create an emotional hook for people. Why is it that this is so critically important? How is it that actually we demonstrate the importance of this at a visceral level? So they are connecting to it. At the moment, it's very abstract with a lot of these things, and we don't get the information out in a way that is coherent, easy to follow, and making the right thing easy to do. So when I talk about reliable in this space, it's actually about making the right thing easy to do. It's not about adding steps. It's about reducing steps. It's about simplifying our messages, focusing on, we may have a process that needs to be followed. What's the consequence if it's not followed? How do we get the emotional hook that sits around that? And I think so many of these things come down to our ability to communicate the why, the how, and the what, and make it easy. If something is not easy to do, it won't happen.
I think we've often lost the link that's so important for clinicians is how does this create harm?
That's the emotional hook, David. And if we don't actually look for that, we're not communicating adequately that risk and the consequence that comes from it. We're missing some of that why that people can respond to.
You then talk about robust, and robust looks at monitoring care processes and identifying those that result in superior patient outcomes. To do that, you have to sort of marshal or collate the patients into groups that are comparable. How can you make sure that you, in the robust phase, you're actually comparing apples with apples?
So there's an element that's right there, David, about cohorting the patients. But sometimes what we're doing is actually looking at those guidelines, the evidence-based practice that you're talking about, and establishing a standard. So this construct that we're looking at, the reliable, robust, resilient, is not to say that one is better than the other. It's to recognise that in different circumstances, with the level of complexity and the level of predictability, we should be applying different methodologies. So where we have a level of irreducible complexity, a level of irreducible unpredictability, we need to be realistic and not try and standardise. What we need to be doing is to try to actually set standards that we can measure against. And those standards might be, for instance, if you're dealing with diabetes, how do we go on monitoring the HbA1c? If we're dealing with other care processes where we can establish this is a standard that we believe we should be moving towards, how do you measure that? Is that an audit process? How do you improve it? Is that a robust quality improvement methodology, like a PDSA cycle, like Lean to reduce waste, like Six Sigma to reduce variation? So these tools apply in that space where you have a level of irreducible unpredictability, a level of irreducible complexity, our real world environment, but where we can set a standard that matters, that has a robust evidence base to it, and measure ourselves against that. And it's a cycle of continuous improvement. So that's what we're talking about in that robust space. Now, yes, trying to cohort patients of similar complexity may be an element of that, so that you know that you're measuring apples and apples, oranges and oranges. We've got tools to do that. We've been using case mix for a very long time. Now, does that have limitations? Yeah, it sure does. But what we're doing here is trying to not necessarily answer questions. It may be that we're looking to ask questions, as it might be that actually our patient cohorts are different. But what it's doing is allowing us to identify areas where we should be focusing, identify areas where we need to be making an assessment. Do we have an issue here or do we not? It's not an answer in itself, but it can be a target and can give us methodologies that sit within this robust space where we are looking to achieve standards and finding the pathways to improve those standards. Does that make sense?
Thank you, Andrew. Yes, it does. The third phase then is resilience and dealing with the unexpected. Often adverse events are classified as unexpected but unavoidable, particularly in a surgical context. Is this label of unexpected but unavoidable simply an excuse for lack of skill, or is it an inevitable consequence of being a human?
Let me flip that. Rather than talking about the absence of skill, let's talk about the skills to deal with complexity. And do we actually focus on how we develop more of that rather than focusing on the absence of those skills? So what are the things that may be in play to allow us to deal with that unexpected stuff and get a better outcome? What are the properties of resilience that may enhance the ability of people who may not have the greatest technical skills, but can deal with changes and perturbations because they're better at communicating. As a team, they are cohesive. They've got each other's backs. They'll talk. They'll engage in an issue. So it's commonly not an issue of the individual skills. It may be an issue of a collective approach. Our ability to deal with complexity, with the unexpected, relates not only to our individual capacities, but the capacities of the team and the capacities of the system. So this is where compliance with protocols, a process-oriented approach, is less relevant. And what we're doing is we're moving to a goal-oriented approach, where we need to acknowledge that a simple trying to treat something as a cookie cutter, as the expression you used earlier, where we can simply sense what we're dealing with, categorize it, put it in a box and apply a standardized approach. Or it might be a complicated issue where we have an expert who on their own can look at a situation, sense what's going on, analyze that and develop a response. And there might be several different types of response that are required. But when you're dealing with something that is truly complex, where there are so many, when we're talking about complex here, we're talking about multiple components that have a high level of interdependence and interrelatedness. Okay, that's when we're talking about complex, that's what we're talking about. And it's very commonly beyond the individual to actually deal with that, because there's too many balls in the air. There's too many perspectives to consider. And that's where you need to bring multiple perspectives in, and where you look at iterating. So we might probe to identify what it is that we know. We then try and make sense of that and we generate a response. But that's not enough. We need to cycle back around and actually see, did we get that right? And very commonly that's going to require multiple heads in the mix. So dealing with that resilient piece where we've got to deal with the unexpected, yes, there is absolutely an element of individual technical skills. And it's a necessary but insufficient component. It really comes down to how we can pull it together, how we can get the multiple perspectives, and how we can actually establish from a principles base how we might move forward.
So we started off with a baseline of 16.6% of admissions having an adverse event. We've poured millions and millions of dollars into reducing it. We're now operating on more complex people. What baseline should we aim for?
Well, this is where that risk homeostasis piece comes in, David. It's not just what we need to aim for as healthcare professionals. It's what's the level of risk that our community, our patients are prepared to tolerate. Because people do have a tolerance of risk. And sometimes when we're dealing with more complex things, we have to accept that actually the chances of things going awry may be higher. But here it comes down to those resilience potentials, again, that Holnagel talks about, the anticipate, the monitor, the respond, the learn. And it's about acknowledging that complexity, accepting that we have continuing risk, and continuing to look for the improvements that we can to not eliminate that risk, not necessarily to actually reduce. Where we can reduce, obviously we should, and we have. And we've done an enormously good job with that. But we've got a tolerance of a rate. Should that be 16.6%? Oh, God, not for me. No, thank you. But it might be that you going in for a complex cardiac procedure might accept that there is a complication rate of 20%, of 30%, of 50%. And acknowledging the level of complexity, if we think that our patients, our community, believe that everything's going to go right, we're ignoring their level of engagement in the risk. Many, many, many times where I've sat down with patients where there's been adverse events, they'll say, yeah, look, this was a really complex situation and I can see that there was many places where this could have gone belly up. But what they're concerned about more commonly is the way that that was communicated or the lack of people actually engaging when they identified problems. So this is about anticipation, being sensitive to where things go, and having a suite of responses that we might use. I have not given you a number, and I don't apologise for that.
I had an interesting discussion on a board that I'm on for a large hospital where the board received a report showing that the hospital's infection rate, particularly urinary tract infection, was well below the 25th percentile, so looked really good in benchmarking. One of my fellow board directors is based in the United States. And she quietly said this would be completely unacceptable in my hospital. So this idea that we develop tolerance, particularly in comparison to our local peers, rather than looking at world best practice, is a fraught concept at times.
Yeah, it certainly can be. And we might say that's good enough. And there may still be juice to squeeze where we can actually do better. And we should be striving to do that. But here's the challenge, David. We've got so many balls in the air, so many things where we want to improve, so many areas where we're being stretched to apply our attention. And sometimes we go chasing after a particular indicator at the expense of the energy that we might be able to direct into other things. So am I suggesting that it's acceptable to have a UTI rate that's higher than in the United States? Well, let's look more broadly at what the outcomes are there. Are they chasing down a UTI rate where, in fact, there's other stuff that they should be doing? When we look at how much they're spending on healthcare and what their health outcomes are, I'd rather have care in Australia. Now, okay, is there ways that we can reduce the UTI rate that actually make it easy to do the right thing rather than adding steps in? Then we should be doing that. We absolutely should be doing that. Do we ever think that we're going to eliminate UTIs? Yeah, no. No, that's highly unlikely. And not in our real world environment. I mean, how do we reduce falls? Well, we can tie patients into the bed. I don't think any of us are going to want to do that. So there's some of these things a balancing act. But, let's take the bloodstream infection rate, for instance. We should be chasing that down and continuing to chase that down and not accepting that, there will be an occurrence rate. But so many of the things that we can do are simple. There's simple interventions that don't add additional time, cost, anything. And engaging doctors in bloodstream infection rate, for instance, you'll not uncommonly find them talking about, well, infection control's a nurse problem. Well, hang on a moment. What's the biggest single thing in our bloodstream infections? It's our vascular access devices. Who gets to choose whether to put them in? Who gets to choose when to go to antibiotics? Who gets to choose when to take them out? How do we engage our patients in that? Do we say to them, if this has been in for more than 2 days, please tell us? Are we using interventions that actually that we know can work, that add no extra work? If we're adding extra steps, then we're diverting attention from other things.
Thank you, Andrew. That's an extraordinary conversation on quality improvement. If you wanted to summarise it just in 1 or 2 sentences, how do we ensure that we continue to improve the health service that we're working in?
Look, the first thing, David, is to understand our environment and understand that it has become more complex. We ignore that at our peril. If we think that we can introduce linear solutions where we have a cause and effect on isolating individual aspects, we're missing that complexity and we're missing the knock-on effects that might occur. So the first is to understand your context. The second is to think about what's the particular situation that I'm dealing with. Is this something where I can apply a tool of standardization? Is this a situation where I need to accept that this is going to be messy and murky and I need to continuously improve and apply the tools for that? Or is this a space where we're truly dealing with the unpredictable? And how do we actually work on the people as the resource in that situation? So it's that intentional approach, stepping towards the situations that we face, not applying a cookie cutter, thinking about what type of problem are we facing? Because there is linear elements within that complexity. And if we can deal with something in that way, great, let's do it, because it deloads the higher end thinking. So it really is about understanding your environment, thinking about what type of problem am I dealing with and what are the tools that I have available to myself to do that. And applying that in an intentional way, communicating that effectively, helping people to see why it is that we're doing what we need to do, getting that emotional hook. And that was one very, very long sentence.
Thanks, Andrew. So we need to standardise the straightforward, look to monitor and continuously improve the complex cases, and for those that are truly unpredictable, make sure we have the right skills across the whole team to deliver the best care. That was Professor Andrew Johnson from James Cook University, a veteran medical administrator and former Executive Director Medical Services at Townsville Hospital, now working as a consultant. And what an extraordinary conversation it was on continuous quality improvement. That brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.